I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the first PRS Journal Club podcast. And we hope that this becomes a tradition. I'm honored to be joined by my co-resident ambassadors, Raj Sawh-Martinez from Yale, PGY5, and Amanda Silva, PGY5 from the University of Chicago. I'm Sammy Sinno, one of the fifth-year residents at NYU, and we are very fortunate to be joined by our first moderator today, who is one of my mentors and very involved with the journal, Dr. Charles Thorne, also chairman at Lenox Hill Hospital, professor at New York University, plastic surgery, and editor of Grab and Smith. And we hope that you enjoy this podcast. Something new that's going to be starting in January of 2016 is that PRS Journal will be designating several articles every month to be journal club articles that are meant for discussion both in the podcast form and then also on social media. And today we hope to review our articles for the month of January with you in a little bit more detail. And without further ado, Amanda, you want to take it away with the first article?
Sure, I'll get us started. So my selection for the January PRS Journal Club is out of France. It's by Bekara and Chaput. It's titled A Systematic Review and Meta-Analysis of Perforator-Pedicled Propeller Flaps in Lower Extremity Defects, Identification of Risk Factors for Complications. So traditionally, when we think of lower extremity reconstruction, the lower third of the leg often requires a free flap for reconstruction. However, with perforator propeller flaps becoming more common, defects in this region can often be reconstructed with this method instead. But this is still a complex procedure, and risk factors for complications and flap failure haven't been investigated extensively. So the aim of this study was to identify risk factors for complications, including flap failure, through a systematic review and meta-analysis. So the authors defined a propeller flap as an island pedicled flap with an arc of rotation of greater than 90 degrees. They identified 40 articles with 428 patients. And the defects were most often due to trauma. They were most often located in the distal third of the leg. And flaps were most often based off the posterior tibial perforator. They found a 25% complication rate. This includes dehiscence, hematoma, and infection, with a 3.5% total flap loss and a 10% partial flap loss. The risk factors that they identified for complications were age over 60 years old, diabetes, and arteriopathy. Risk factors that they analyzed but were found to not be significant were acute etiology, a post-traumatic etiology, the presence of a bony fracture, location in the distal third of the leg, fascia inclusion in the flap, a surface area greater than 100 centimeters squared, a pedicle rotation greater than 120 degrees, and whether the patient was a smoker or not. However, that risk factor did reach near significance. So limitations to this study is mainly the heterogeneity of all of the studies that were included. However, I found this article to be informative for knowing the demographics for use of and the risk factors for complications when considering this option for lower extremity reconstruction. Additional articles that we included just for further reading on this subject are the evidence-based medicine article by Halleck on lower extremity reconstruction. It's a wonderful discussion on options, including perforator flaps, and it also includes multiple videos. And then the other two articles are by Cheverin and Sincere and Martin and Morris. And both of these articles are anatomic studies which help guide flap design and dissection for lower extremity perforator flaps. So now we would just turn this over to discussion.
No, that was great. Dr. Thorne, I'm sorry, we haven't given Dr. Thorne much of a chance to talk. How are you, Dr. Thorne?
Yeah. Delighted you included me. So, what's the indication for this type of flap? Or what's the advantage of it?
So the advantage is that you don't have a long procedure. Free flaps are long procedures, so that would be one advantage. I think that something that they don't really touch on in the article, which I think would be really interesting, is to look more, rather than just saying lower third of the leg, which is what they mentioned, to actually look where in the lower third these defects were located and how large they were. Because I feel like sometimes, even though people are using these propeller perforator flaps in the lower third, there are still often defects that are large and extensive and even further distal on the leg that you're not going to be able to reach with one of these flaps. So although the donor
sites are presumably skin grafted, is that right? Particularly on a post-traumatic leg?
Right. So in this study, some were primarily closed. Some did require a skin graft. I believe it was about 50-50.
What's interesting, I heard a microsurgeon say this once about some of these propeller flaps, that even though they're not free flaps, you still have to treat them as, in a sense, microsurgical flaps, because they are, and it's nice that this study came out and showing how widely used, but also how they can be prone to certain complications, and they should be monitored probably just as vigilantly as free flaps in terms of flap loss and necrosis, et cetera. So I've seen a couple of these in my training, and they definitely are very nice to perform when they're an option, but it's nice that they were able to identify some risk factors, because they shouldn't just be thought of as a typical local flap.
A part of the difficulty, it seems like, too, is just the lower third, right? I mean, the fact that we need to do free flaps as the sort of common standard for that. And even the risk factors here, it seems to have some overlap with some of the issues that we have with free flaps in general, right? I mean, the greater age, diabetics, any arteriopathy, it's in addition to just being a complicated flap to do, but just that the whole lower third, I think there's something there about the venous stasis, the gravity effect. I don't know, Dr. Thorne, what are your thoughts? You probably have a lot more experience than we do with these. Do you think of them similarly?
I don't have any experience with these. But I'm interested that, this is obviously a very elegant operation and a very elegant discussion. In real life, practically speaking, is there an advantage over transferring this tissue as a fasciocutaneous flap? Does it make it less subject to these free flap complications?
I think operative duration. I think you're going to have a shorter operation, although that's just speculation, because they didn't look at, no one's looked at comparing that. But usually it's a shorter operation if you're doing a pedicle perforator flap versus a free flap.
Right, but how about a non-free fasciocutaneous flap? What if you just, in other words, you use the same flap, but not as a complete island, just as a rotation flap?
You probably get more freedom of rotation, and you're able to advance the flaps further if you're dissecting out along the perforator.
Right, and you can bring more tissue. I think that's sort of the geometry of these propeller flaps, that it allows you to bring in good tissue, whereas the lower third is typically limited by smaller flaps that are typically used for reconstruction. That's why it sounds like still to this day, free flaps are the gold standard for reconstruction of the lower third. Amanda, you said, though, I think you pointed out that's probably going to be a future study by either these authors or somebody else, is comparing free flaps to propeller flaps head to head and similarly.
I think that'd be interesting. But I think also, like we mentioned before, a lot of times the defects will determine what you're able to use. I think that these flaps are limited by the defect. I think once you get to a certain location or size, that free flap will still be the option. It's not like they're necessarily, it's more the defect that determines what type of flap you need to use, not just the location that it's in the lower third of the leg.
Right.
Oh, great.